Hello everyone. Today on 8th October, we observe World Hospice and Palliative Care Day. I'll be giving a small talk about this day. It is an annual unified day of action to celebrate and support hospice and palliative care around the world. Myself, Dr. Mario from the Department of General Surgery, St. John's Medical College, Bangalore. This year's theme for World Hospice and Palliative Care Day is Healing Hearts and Communities. So healing hearts and communities because we experienced more than 6 million deaths worldwide during the COVID-19 pandemic, resulting in tremendous strain on healthcare system and grief and suffering for healthcare workers and caregivers. In addition, several conflicts and wars are taking place around the globe, resulting in millions of families and caregivers grieving the deaths of family and friends, experiencing social isolation and property destruction. So what is palliative care? According to WHO, palliative care is an approach that improves the quality of life of patients and their families who are facing the problems associated with life-threatening illness. It is done by prevention and relief of suffering by means of early identification, correct assessment, and treatment of pain and other problems which can be physical, psychosocial, or spiritual. So these are the various aspects of palliative care. It provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process, enhances quality of life, offers support system to help patients to live actively as possible until death, intends neither to hasten or postpone death, integrates the psychological and spiritual aspects of patient care, offers a support system to the family, uses a team approach, and it is also done in conjunction with other therapies such as chemotherapy and radiation therapy. So hospice is a place to live which adds life to days and not days to life. So hospice care is end of life care provided by health professionals and volunteers. They give medical, psychological, and spiritual support. The goal of care is to help people who are dying have peace, comfort, and dignity. The caregivers try to control pain and other symptoms so a person can remain as alert and comfortable as possible. Hospice programs also provide services to support a patient's family. So what is the relationship between curative and palliative care? So we know what is palliative care. It is to relieve suffering in order to improve quality of life. So persons receiving palliative care have a right to choose their treatments and may also receive curative treatment alongside palliative treatment. So palliative care professionals closely monitor these patients for symptoms and will advise if curative treatment may be adding to their suffering, thus allowing them to make informed choice as illnesses progress or improves. So healthcare includes palliative care and there is no universal health coverage without palliative care. So palliative care is attention and care for chronically and terminally ill persons, sparing them avoidable pain and enabling them to die with dignity. So patients with life-limiting illnesses should have access to appropriate healthcare, basic medications for symptom control and terminal illnesses, and there should be national healthcare policies. Now, 14 palliative care medications are currently on the WHO essential drug list. So 56.8 million people require palliative care every year. Among them, 7% are children and 67% are more than 50 years. And of all the deaths in 2017, 45.3% required palliative care. So these are the various symptoms or problems these terminally ill patients face, which can be, bleeding, constipation, dry mouth, or it can be depressed mood, anxiety, worry. So palliative care aims to address, decrease all these symptoms of suffering, alleviate them, mitigate them, or at least decrease them, thereby improving patients' quality of life. So what are the main barriers to palliative care development? One is policy. So policy by the government is therefore seen as a fundamental component because without it, other changes cannot be introduced. So in some countries, there is no government support at all, whereas in some countries, there are charitable palliative care services available. Then you need education, medication availability, implementation, health workforce is required, and there are barriers of psychological, social, cultural, and financial in palliative care. So vast majority of health professionals worldwide have little or no knowledge about the principles and practices of palliative care. but there has been growing body of knowledge in palliative care in the past 50 years. So we have at least 14 professional journals now about palliative care, and there are a lot of peer-reviewed journals, literature, books, internet sites, blogs, and forums. So palliative care education is needed at three levels: basic, intermediate, and specialist. So basic palliative care education is required for all healthcare professionals and paraprofessionals. Intermediate palliative care education is required for those routinely working with patients with life-threatening illnesses. And specialist palliative care education is required for more complex symptomatology, management needs, and for those who are involved in teaching palliative care and research. So, as we saw, pain alleviation is one of the main component of palliative care. So, 84.25% of world population lack adequate access to opioid medication for pain management. So, as you can see in the map distribution, there is inequality in consumption and distribution of opioid analgesics and other opioid related analgesics in these patients. So Australia, Canada, New Zealand, United States, and several European countries accounted for more than 90% of the global consumption of opioid analgesics, while low and middle income countries consumed only 10% of global opioids. So how do we assess pain? So we use a visual analog scale to assess pain in addition to clinical examination. So we have this WHO analgesic ladder proposed in 1986. So WHO recommended the analgesic ladder for a structured approach to manage pain as seen in patients with cancer. So the aim was to recommend simple method of utilizing analgesics that are safe, economical, and effective. It was meant to empower health professionals across the globe to approach pain with empathy and improve competence in managing pain and relieve the needless suffering due to pain in cancer patients. So by mouth, oral analgesics, ease of drug administration. It is manageable by family at home without need for healthcare professionals, as the drug is needed as long as the pain lasts, which could be lifelong. By the clock, continuous pain requires continual analgesia. If prescribed only when patient screams with pain, then pain relief is unsatisfactory. Also, the total analgesic requirement shoots up. By the ladder, move up and down the ladder and use the recommended class of drugs based on the type and severity of pain and not on the poor prognosis or terminality of illness. So, as you see, the ladder goes up. In the step 1, for mild pain, non-opioid analgesics and adjuvant drugs are used. In step 2, mild to moderate opioids with, if required, step 1 is used. In cases of severe pain, strong opioids along with step 1 is used. So this original WHO ladder was unidirectional, starting from the lowest step of NSAIDs to opioids. However, the real limitation of the original scale was the impossibility to integrate non-pharmacological treatment into therapy path. So as a consequence, the fourth step was added to the ladder, which includes numerous non-pharmacological procedures that are robust recommendations for treating persistent pain. So it can be epidural analgesia, intrathecal administration of drugs, pumps, neurosurgical procedures, neuromodulation stimulation, nerve blocks, ablative procedures, radiofrequency, cryoablation, etc. So this updated WHO focused on the quality of life and was intended as a bidirectional approach. For example, in acute pain, the strong analgesic is the initial therapy and later toned down, whereas for chronic pain, employing a stepwise approach from bottom to top can be used. So in cases of chronic nociceptive pain on an inflammatory basis, it would be more appropriate to use steroids or NSAIDs. On the other hand, low inflammatory nociceptive pain should have received treatment with opioids and non-opioid analgesics. Finally, neuropathic pain may require antidepressants or anticonvulsants and specific drugs in certain rheumatologic clinical conditions. So International Association for the Study of Pain suggested adopting a therapeutic approach more focused on the type of pain, that is the mechanism, and on the mechanism of action of the drug used to treat it. So we have the public health model for palliative care development. As we saw earlier, it includes most importantly the policy, the drug availability, equitable availability to everyone, and education to the healthcare professionals, paraprofessionals, and even public, and implementation. So what is the minimum package required for a palliative care service? It is a drug, medication, medical equipment, and human resources. So what are the drugs, minimum drugs required? So it can be amitriptyline, loperamide, naloxone, omeprazole, ondansetron, haloperidol, painkillers, paracetamol, morphine, lactulose. These patients have constipation, and medical equipments like pressure reducing matters to avoid bed sores, pressure sores, urinary catheter, NG tube, nasogastric feeding tube, diaper, and you also need human resources. So as I said earlier, this is a team approach. So it requires doctors, nurses, psychiatrists, psychologists, counselor, pharmacist, physical therapist, community health worker, clinical support like imaging lab technician, even dietitian, and non-clinical support staff is also required. So palliative care is a topic that people avoid thinking because it speaks of death and dying, or fear of dying. So when you start talking about death, they stop listening. So we have to change our approach. More education is required, language should be reframed, and talking about a better life rather than end of life, improving the quality of life, that would work better for us. So with one voice, we will celebrate the importance of palliative care to quality of life and advocate for equitable access for all. Thank you.